Hello and welcome to the Unit 3 presentation on communication. This is one of two videos for this unit, so please make sure that you view the presentation on documentation also before we get to class. These are some of your learning objectives for the unit. The rest are listed on the documentation presentation, and there's a complete list in E360 and on the learning plan that you guys were all given. So before we can effectively communicate with those around us, especially our patients, we need to first look at our own communication styles and evaluate how we send our messages and how they're received. Are we constantly throwing out cues that we don't really want to talk to people, or are we cutting other people's thoughts off before they can tell us what they need to? Well, one way to evaluate our communication style is through the use of a process recording. This is a tool where our conversation is transcribed, and then we analyze the conversation, looking for cues for both therapeutic and non-therapeutic communication that might have taken place. So we're going to be completing a process recording in this class, and you'll also need to remember it for your other classes. Going over these process recording gets us thinking critically about ourselves and provides opportunities for personal growth. We'll go over the process recording basics in class as well. So therapeutic communication is an essential part of the nurse-patient relationship. When we build rapport with our patients, they're more likely to discuss personal information with us, and this is going to add a great deal to our assessment and plan of care for the patient. And also by engaging in therapeutic communication, we're practicing holistic nursing care. We're caring for the whole patient, body, mind, and spirit. We're telling them that we care about them and that we really want to help them get through their personal situation. Sometimes our act of kindness or taking time for therapeutic communication is really the only time that that patient felt cared for during the whole day. So it really can make a huge impact on our patients. And therapeutic communication includes both verbal and nonverbal communication. A few things to consider with our verbal communication are things like pacing, how fast and slow are we speaking, intonation, what's our tone of voice. If we talk in a patronizing or condescending tone, it's going to change the message of what we're trying to get across. Clarity and brevity, keep it short, simple, and direct. Less words is less confusion. Timing and relevance. Poor timing is going to result in poor communication. So if your patient is having acute pain, you probably want to manage the pain before you try to do the therapeutic communication, because that's going to affect their ability to participate fully in it. And then communication isn't just what we say. So the nonverbal communication is how we maybe look when we're communicating. So for example, if you've ever had a discussion with someone and you're in mid-sentence and they roll their eyes at you, well, that just changed the whole tone of the conversation, most likely. So think about things like personal appearance, posture and gait, facial expression. The face is the most expressive part of the body, so we want to try to avoid showing shock or dismay if we're walking into a room that has a patient with a big gaping wound, because it might scare them even more than the wound itself just to see the look on our face when we look at them. And then eye contact. So sometimes lack of eye contact shows anxiety or lack of confidence or discomfort, but sometimes it's just a cultural thing, and in some cultures, if you make eye contact, it's seen as rude or disrespectful. So we have to take into consideration what else is going on. Other nonverbals would be gestures and sounds, and then personal space. Remember to respect the patient's need for personal space, and if depending on what you're doing, you might need to be closer to the patient if you're doing a physical assessment, but if you're just getting a health history, you can sit further back from the patient, and that would respect their need for personal space. And meta-communication is just a term, if you're not familiar with it, this is all the factors that influence communication when verbals and nonverbals don't match up with each other. So the nurse-patient relationship is considered a helping relationship, and there's generally 4 phases to the relationship. Pre-interaction takes place before we even meet the patient. These are reading, getting the chart ready. thinking of a place where we're going to have this interaction that's private, planning enough time. Introduction, orientation phase. This is where you first meet the patient. You want to establish rapport, and you want to make sure that you get off on a good foot, because first impressions are going to set the tone of the whole relationship. If you establish a good rapport, then this lets the patient, like we said, gain trust, open up. More detailed and accurate assessment data you can get from the patient that way. And know that the initial relationship's oftentimes superficial, and the patient's going to test your competence. They're going to be watching you to see if you really know what you're doing, and you're going to be watching them just to observe them. And after you get this observation done, you're going to be inferring or judging or making judgments about witness behaviors and giving an overall or getting an overall idea of the patient's health status. You're going to prioritize problems and clarify the patients and your roles, lay out expectations, and let the patient know when the relationship's going to be terminated. Working phase is the next phase, and this is where the exploration of feelings takes place. We're getting our point done that we wanted to get done in this conversation. The information is given to you by the patient, but you're also giving the patient information. Goals are set, and the nurse is going to use therapeutic communication here, and sometimes the blocks come up, and that's why we do this process recording, so we can kind of get a better idea of what to say and maybe what wasn't so good to say. Sometimes part of that is using self-disclosure and confrontation if you need to. And then termination is the last phase, and this is where we get the closure. We're going to remind the patient that termination is near, so you might want to say something like, I'm here until 6 p.m. and then I'm going to give a report to the oncoming nurse. And then also evaluate goal achievement and separate from the patient by giving over responsibility for their care. So we don't just leave, but we need to hand off to the next caregiver. So we might need to introduce the oncoming nurse or give a bedside report handoff to cut down on errors or some sort of thing like that. So how do we develop a trusting relationship or a helping relationship? Well, it's important to develop rapport with our patients. This allows them to trust us and get the most out of the nurse-patient relationship. So this slide lists some ways to develop a helping relationship. And just remember as you read through it that patients can sense when nurses aren't sincere or they don't really want to be working with them. And these negative feelings that they might feel towards us, if they're getting that, that sensing of us not wanting to be there, that impairs the relationship and the level of cooperation with the patients and the family. So they're not going to want to divulge personal information to you if they feel like you don't really want to be there interacting with them anyway. Physical attending using solar is another way to develop the helping relationship. And this is a good example of a variety of nonverbal communication techniques we can use to do that. And it shows people that we're interested in what they have to say. And then attentive listening does much the same thing. This is paying attention to the whole person and the total message that they're giving. And this is a crucial skill to develop. This is both the verbal and the nonverbal communication and the content and the feelings that the patient's expressing. It's looking at everything in conjunction so that we can treat our whole patient and we can treat all those 3 domains of nursing for holistic care that we talked about from week 1. So this chart is from your text, and it lists a variety of therapeutic communication techniques, so be sure you know and understand how to use these. So if you need to pause and review them, that's great. Otherwise, there's a handout on E360 also that talks about it, and we're going to be practicing it more in class also. Then non-therapeutic communication. So non-therapeutic communication is the opposite of therapeutic, right? It's anything that puts up barriers or blocks to the patient exploring their feelings. We've got a few examples here of things that we should try to avoid. And it's equally important to understand and to be able to identify non-therapeutic communication as it is therapeutic communication. And just to point out, there's a video on E360 that I'd like you to view, and this shows role-playing examples of barriers to communication, and it does a really, really good job of relating them to professional versus unprofessional communication and therapeutic versus social interaction. So please give that a look over as well. Then we'll talk a little bit about communicating with patients with special needs. So if we're communicating with these types of patients, we want to make sure that we take into consideration what their needs are. So if they're hearing impaired, for example, you want to make sure the patient knows you're talking. So face the patient, make sure your mouth is visible, don't chew gum, don't exaggerate your lip movement. Speak slowly, but not excessively slow. Make sure the patient has appropriate assistive devices, so they might just need their hearing aid in, so make sure they have that. Allow time for the patient to respond, and this is really important for the people that have difficulty getting their thoughts out loud. Just give them time to get their thoughts out and give them time to ask questions. If we're talking about non-English speaking patients, we want to know how what their primary language is and how are their English skills. And we may need to get an interpreter to help with this conversation. And remember that nodding does not mean they understand. Many times the patient's going to nod that they understand because they're embarrassed to admit that they don't. Provide written information in English and the patient's primary language. And just remember, we don't need to talk louder to get them to understand. That doesn't help unless they're hard of hearing. And for any patient, make sure you're talking in terms they understand. Please don't use only medical terms, but instead use terms that a layperson would understand. So for example, you wouldn't want to say to the patient necessarily, boy, you're hypertensive today, because they might not know what you mean. Instead, you would say something like, oh, your blood pressure is really high today. So just keeping those things into consideration. A primary nursing role also is to advocate for our patients. And sometimes this conflicts with the provider viewpoints, and that's okay. We just need to make sure that we have collaborative relationships with those providers and that we can discuss what the patient maybe needs or wants with that provider. So an example that I can give you is that sometimes providers will see a terminally ill patient, and based on their training, they're going to think, I need to save this life, I need to save this life. And so they're going to recommend to the patient's family that they start dialysis. As a nurse, though, we need to think about the end goal, and we need to think about quality of life as it's interpreted by the patient and the family. So we need to think about maybe the patient has said they don't want heroic measures. Well, would they consider dialysis a heroic measure? It's hard to say without asking them, you know. Would the patient even want dialysis? Is it going to change the patient's outcome, or is it just going to change, or is it just going to cause the patient suffering? So we need to have all these discussions with the patient or their family, and then we need to advocate for that patient and tell the doctor, you know, yeah, the patient really wants to do this, or, you know, that I talked with the patient and they really don't want to do dialysis. Could you go talk to them again? And the last thing there is limit setting. And what this means is that sometimes we have to set limits for our patients to keep them safe. So an example would be if you have a patient that's a fall risk, we're going to set the limit that you can't walk down the stairs because we don't want you to fall. And then the standard process for communication in healthcare is the use of SBAR communication. So we really need to know this SBAR business frontwards and backwards. Okay. This is situation, background, assessment, and recommendation. And using SBAR is important because it's going to help prevent miscommunication between the healthcare team. And it's especially important if you're communicating with a provider that doesn't know the patient. So if you have a provider that's maybe taking call overnight and you have to call them about a patient and it's not normally their patient. The details that you give them is going to help them get a better picture of the patient's problem and how it should be treated. So, what's important information to include? Well, anything that the oncoming care provider would need to know, and especially any problems or unresolved issues. So, for example, I might report off that I gave the patient pain meds, but their pain is still a 4 out of 10. I'm waiting on a callback from the provider. Can you follow up on that on your shift? That would be appropriate. You don't want to give unimportant or implied things like, well, I assessed the patient today, or, oh, I charted all the meds I gave, because these are kind of given things. Be sure to fully understand SBAR. Like I said again, you'll need to know it because it is the standard in communication. And then this slide just shows an example of a home health nurse calling the patient's physician with some concerns using SBAR. You want to maybe pause and review the SBAR communication, and that will be helpful just in giving you an idea of how the flow of the conversation would go. So to recap, make sure you can answer these bullets on the slide, and if there's anything that's not clear to you, you might want to go back and review that in your reading or in the PowerPoint presentation. Thanks for listening and have a great day.